A very good day, my dear postgraduate students. Welcome to Recent Advances after a long break. The authors for today's class shall be Sunil Lakhani and John Sloan. The topic being pre-malignant conditions in the breast. This appears to be a fairly simple, oft-repeated topic, but then if a question like this were to be asked, how fluently will we be able to answer the essay? With this, we shall take the plunge. Always an index. An index shall be a reflection of the contents of the class. And classification is an aid to orderly thinking. Now, I would like you people to kindly look at the various terminologies on the screen. Ductal carcinoma in situ, lobular carcinoma in situ, atypical ductal hyperplasia. And then there is a plethora of miscellaneous topics such as fibroadenoma, adenoma of the nipple, so on and so forth. So it becomes our profound duty to encompass all this and then deliver our class, which means there should be an orderly thinking. Therefore, once you people do this, half your job is done. Coming to the introduction, pre-malignant lesions, as the term means, are by themselves not malignant, but have a greater probability towards malignancy. And the CA of the breast is a multi-step process, as you would have learned elsewhere. In order to understand the pathogenesis, mammographic screening has become very essential because what we are getting is a resected specimen or a biopsy. But then a biopsy, a mammogram will be able to give us a preliminary idea of the lesion within the ducts and the ducts. Also, it has been mentioned that by this condition or technique, it is difficult to differentiate the benign from the malignant. Courtesy research for this beautiful diagram. I am seeing here a normal duct. There is an epithelium and the myoepithelium. When the various hormones act on it, you find that there is a kind of a change within the lining epithelium, but the basement membrane and the smooth muscle appear to be intact. This change continues, and then you find that there is a proliferation of the cells with all the qualities of a neoplasm. I will not delve into it too much. And finally, you find that there is a breach in the basement membrane. There is no smooth muscle as such, and then there is an invasion leading on to a metastasis later. In all this, you find that endocrine factors, genetic and epigenetic changes play a vital role. It shall be my profound responsibility to deal with these topics later on. But today, we shall confine ourselves to the precancerous lesions in the breast, to which it has been mentioned that histopathological changes, animal experiments, and genetic sequencing have played a role in unraveling the mystery. Earlier, animal experiments, as I had mentioned in the first slide, they had been seen to play a role, as in the case of a mouse mammary tumor virus, earlier called the bitterness milk virus. There is a normal epithelium which proliferates, and hence there is a hyperplastic alveolar neoplasm which can arise out of it. And these subsequently result in a carcinoma. This is an age-old theory that is there. Secondly, what do you see in histopathological material? You find that there is some kind of a correlation between the cytological and the histological features. And whenever there is a gradual development, you are able to identify the morphological transitions. This is extremely important. You are able to compare the benign changes in the cancerous and the adjoining non-cancerous breast. This is extremely important. Even this morning, we had reported a slide on an infiltrating ductal carcinoma, and the adjoining breast was showing features of sclerosing adenosis. Comparing the percentage of cancer development and following up the pre-malignant lesions. It is only with these two, the animal experiments and the human histopathological material, that we are able to study the sequence of development of the precancerous lesions. And to add, the genetic analysis. You find that there are various steps in it. The genetic changes are shared both in the precancerous and the cancerous lesions, which means there is some genetic abnormality and then the cell becomes malignant, but then the same genetic abnormality persists. At the same time, it has been mentioned that changes in the benign and the malignant can be because of the same phenotype to which they belong. And all genetic abnormalities need not be or cannot be studied. And it is not possible for staging all this. Therefore, there is still a limited role for genetics. Perhaps the future will tell us what is in. But then this is a post biopsy or a post clinical wisdom that you would see in all the books. The age of the patient in breast cancer and adjoining or a coexisting covariant cancer, then two primary breast lesions, a second breast cancer at any age, triple negative, less than 60 years of age, then there is a family history, male member also developing a breast cancer, and the Ashkenazi Jews, because of their genetics as well as the habit, you find that they are more prone for malignancy. This is one of the most important things, the ductal carcinoma in situ. In situ means in position. Now, this can happen in proliferative breast diseases. Normally, there are the various sequences, epithelial hyperplasia. There is simply a multiplication of the epithelium in which the malignant transformation is less 1.5 to 2 times alone. At the same time, when there is some atypicality, it increases to 4 to 5 times. And the same is in the case of a ductal carcinoma in situ, which is 4 to 5 times. At the same time, an intraductal carcinoma will be having 8 to 10 times. And 50% of the cases will be recurrent. This again is a beautiful picture of it. The reference is R.A.T.S.com. It is a beautiful article, kindly read it. I hope you people are able to appreciate the epithelium, the myoepithelium. And there is a hyperplasia, as I had mentioned in the first slide. At times, you find that there is a piling up, there is a loss of polarity, increase in the nuclear cytoplasmic ratio, so on and so forth, which is called an atypical hyperplasia. Finally, the changes are too very obvious. It is involving even the basal layer as well as the cells that are filling up the lumen. A ductal carcinoma in situ. At the same time, the basement membrane remains intact. Finally, there is a breach in the basement membrane wherein you get an invasive ductal carcinoma. These terms and the diagrams you shall and will remember. This will form the backbone of our class. And there is a grading. It can be low to no grade or grade 2, which is moderate, grade 3, which is faster, poorly differentiated. There can be features of comedonecrosis. So these things by Chapman et al., I would like you people to read. This is one of the references I have quoted at the end of the class. Again, in rectal carcinoma in situ, you find that there is a heterogeneous group of proliferations. Your Robbins would have mentioned, whenever we talk about a proliferation or spread of a lesion, there is a particular clone of cells which has got that specific property, maybe for differentiation, some for secretion, some for breaching the basement membrane. Each one is a specific clone. Therefore, it is a heterogeneous group of proliferation and not one. And at the same time, the proliferations are also multiple in nature, as I will be showing you in the subsequent slides. Take this for example. So I am finding the growth in the epithelium, there is some amount of secretory change which I can see, but there is a lack of the fibrovascular core, there is no proliferation of the myoepithelium into it, and there is definitely a sieve-like cribriform pattern which I can make. So this is uncommon to be made out in mammography. It can be solid, comedo, cribriform, micropapillary, etc. So there are various patterns which are possible. Hypersecretory is one. The ductal carcinoma in situ can become an invasive carcinoma after a period of about 5 to 6 years. Talking about the patterns, I have mentioned it. Now see what is happening. There can be papillary, fern-like projections within the duct. There can be a fibrovascular hood. Micropapillary, small tufts and within the duct. A cribriform pattern with fenestrations. Comedonecrosis may or may not be present. Solid, there is absolutely no space and the entire duct or the lobule is filled with the tumor cells. Comedo, the central necrosis, as we have already seen. And finally, the invasive ductal carcinoma, where there is an erosion of the basement membrane. So, the architectural and the growth patterns have been included. However, there is a doubt regarding the clinical relevance of these. Though it is said that papillary has got a good prognosis or a bad prognosis and so on. See what is happening over here. There are multiple papillary projections that are coming into the lumen. And it is called as micropapillary because without the help of a high power of a microscope, these would not be very much appreciated. The necrosis can occur in subgroups other than the comedoforms also. Nuclear grading does not match the comedo necrosis. And the high nuclear grade, the non-comedo lesions can also be taken to importance. They may express biological markers and behavior similar to the high-grade comedo lesions. So it is not the appearance or the necrosis that matters when it comes to the behavior of the. Thanks to ResearchGate for this wonderful picture. Van News Prognostic Index. This many of you people would have known, you would have done a study on this, presented papers, etc. So basically you find that there are 3 scores over here and 3 elements are taken into account. One is the size, 2 is the margin or the clearance, and 3 is the pathological classification or rather the histocytology, where it is a non-high grade, then a high grade, non-high grade with necrosis, high grade with or without necrosis. And this is the one. They are the main predictors for the local breast recurrence as well as the development of the tumor. Van Neer's Prognostic Index scoring system. Ductal carcinoma in situ, again a cytogenetic analysis. Cytogenetic analysis, what I would advise you people is, as and when you people come across the numbers of the chromosomes or the alphabets along with, you find, make a list of it and let it be jotted down by the side of your text. There can be anomalies in chromosome 1 and 16 as well as polysomy in 3, 10 and 17 identified by FISH technique. And also you find that the paraffin embedded material can be used for it. There can be other abnormalities such as loss of heterozygosity, 1p, 3q, etc. It is a very long list that has been given. So in short, you find that there can be a lot of chromosomal abnormalities varying in number, the short arm or the long arm, and the position, and ultimately the various changes within them. That having been said, what is the basic difference between an atypical lobular hyperplasia and lobular carcinoma in situ? If it is going to be typical, then there is not much of a problem. Between these two, there is always a difficulty in making a diagnosis. And please do remember, atypical, it will be having about 4 times, whereas lobular carcinoma in situ can lead to about 8 times greater risk of a malignant spread. These are similar but subjective. That's the first danger. In this case, atypical, you find that it is slightly distended. The lobules are slightly distended. Whereas in lobular carcinoma, there is a marked distension of the lobule. First point. Central lumina can be identified. But here the lumen is completely filled, which means it is a solid lesion. I'll be showing you a picture. Less than half the acini of the lobule are affected. Here almost all the acini are affected. Probably there is some insulting force, therefore the entire unit gets affected. Other cells such as the spindle cells and leukocytes may be seen, whereas it is monomorphic, composed of the neoplastic lobular cells. Definitely, I feel you people should by heart this. Useful in a number of contexts. Microdissection. Again, I am not going to go too much into the numbers that I have shown in the blue. I would like you people or request you to kindly read them up. Whereas microdissection is the technique. Nowadays, we are finding a localized hyperplasia or an atypical hyperplasia or a papilloma, ductal papilloma, etc. Now, what are we supposed to do? We cannot do a mastectomy and then declare that it is a benign lesion. At the same time, we cannot ignore so that the patient lands up in metastasis. What is being done is a microductal surgery. Now, after a mammogram, or rather a ductogram, which is more specific for that particular unit, the specific unit is displayed and then it is removed. And some of the surgeons, oncosurgeons, they take care also to do a dissection of the draining alveolar or the axillary group of lymph nodes. So these are the various changes I would like you people to see. There can be the CRB2, then TP53 genes, as well as the TP53 mutation, which can be seen. And also you find that there are certain chromosomes and units which are used for spreading, called the spreading clones. So this is a micro dissection. Look at this one. This particular unit has been removed as such, and it is being studied. Almost like a needle biopsy. The lobular carcinoma in situ, again from pathology outlines, these are the things. It has been recognized by Foote and Stewart, 1941, and it is recognized as precancerous at a later date. Morphologically, there is a similarity between the in situ and the invasive carcinoma, and there may or may not be any transition. Precancerous lesions, if given time, as I told you, will definitely turn to malignancy, and there can be a wide extent of even up to 5 or 6 years. And therefore, Higginson is one person who preferred the term in situ carcinoma. It can be multifocal, it is bilateral. That is a specialty of the lobular carcinoma, whereas a ductal carcinoma is usually unilateral and it is unifocal, whereas it is bilateral thanks to the anatomical configuration of it. And there is an increased family history in this case. You'll have to look at the histological criteria, identify the monomorphic populations which appear filled, but then they are non-cohesive. They have a thin rim of cytoplasm and an increased NC ratio. I hope all these points are. So they are filling up. There is a distension of the lobule. There is a bulging of it. There is no area of lumen, etc. And the cells are all small, but still there is a mild pleomorphism, very thin rim of the cytoplasm that is seen over here, and multiple units are being affected again. Hyperplasia of the usual type. So this you people should be knowing. There is a hyperplasia which can be epitheliosis called as papillomatosis or non-atypical hyperplasia. It is more common in the cancerous base. So this is unfortunate. Sometimes we will be getting a biopsy of this and say that there is only hyperplasia, no malignancy, whereas the adjoining region may be showing malignant changes. These people were prone for it, Anglos, Hispanics, and American Indians, probably because of their habit or a late marriage and so on. Cancerous risk, 1.5 to 2%, or they have got multiple partners. We do not know. Chromosomal aberrations, loss of heterogeneity, which we had mentioned. And these can be some of the abnormalities mentioned for hyperplasia. You find that it is much lower than atypical ductal hyperplasia and the ductal carcinoma in situ. That is the malignant transformation is low. This is again a question for us, but that is not my purpose. The radial scar. As you people see, you find that there is a scar, there is a central depression, and it is otherwise called a complex sclerosing lesion also. So there are many things, sclerosing papillary lesion or infiltrating epitheliosis. It is not a tumor by itself. And it has been called the fibroelastic core. And it has got a flowering head-like appearance. Compare these two, you people will be able to make out. The whitish region is all indicating the scar. A complex scar is more than 10 millimeters, whereas the radial scar will be less than 10 millimeters. And according to this, you find that more than 3% of the cases can go in for malignancy, thanks to basic medical key. And there is the histological counterpart of it. I am able to see the thin strands of the fibrous tissue, and then they are encompassing incompletely the florid epithelial hyperplastic regions. But then it is all a radial arrangement, as you people might see in a case of a peptic ulcer. So central core of entrapped tubules resembling invasive carcinoma. Sometimes it can be difficult for us to make a diagnosis. There can be a higher incidence of DCIS and LCIS. Second opinion always will make a difference. So there can be ductal carcinoma, which is possible. And in some cases, there is an association between the benign and the malignant. Some people have said that there is about 2 times more carcinoma, and some people have said 3 times more. It is not related to the size as such. Naturally, with this kind of a behavior, we cannot anticipate the proliferation. And there is a higher power of it, thanks to Science Direct and Basic Medical Kit for this wonderful pictures. I hope you people are able to appreciate it, and definitely we are in a dilemma. Whether it is the tumor gland that is infiltrating or it is a normal gland that is being surrounded by a desmoplastic reaction. Sclerosing adenosis, okay. There can be the acini of a lobular unit which is undergoing a proliferation. It can be mistaken for an invasive carcinoma. Perineural and vascular dystrophy have been described. The lobular architecture, however, is retained. As we had seen in that picture, the entire lobule is there. Luminal cells, myoepithelial cells, thank God, are present. This is what we are supposed to look for. And in situ can be cytokeratin and smooth muscle actin are positive. There can be a carcinoma that can be superimposed, we'll have to rule out. Hence, cyto and histomorphology are needed. And this will be the thing. When there is going to be a sclerosing adenosis, along with atypical ductal hyperplasia, the malignancy can be nearly 7 times. So again, a picture of it. Frankly speaking, it is very difficult for us to make out whether it is a malignant tumor that is infiltrating the stroma, or it is a sclerosing adenosis or a desmoplastic stroma encompassing the normal proliferating glands. Papilloma. It is again a very favorite friend of mine. Before I go to the text, I would like you people to see this picture. An arboriform pattern. An arboriform pattern, it can be gross, it can be microscopy, as you see in the case of papillary carcinoma of the thyroid. There is a branching and a rebranching producing a tree-like appearance. Why this is important? Because the papilloma can be solitary or multiple. And many of the patients, particularly when it is in the main duct, they present with a nipple discharge, and it is supposed to be a classical bloody discharge is diagnostic of a papilloma. However, 2 layers will be there. The epithelial and the myoepithelial, mitosis, pleomorphism, necrosis are all not that common. There won't be much of an atypical hyperplasia, but it may be present. And if there is an atypical ductal hyperplasia, greater chance of a malignancy. Solitary papilloma in the main duct, multiple can be occurring in the terminal ducts and ductales. So there is a coexistent malignancy, papilloma to carcinoma. Now, what is important is there in this picture. It is a hypol. I hope you people are able to find out the fibrovascular core. There is a branching and the rebranching. And unfortunately, when we do take a section or when a bit is being given, there is a branching pattern. Therefore, it spreads into the adjacent region. But each of these are being surrounded by the ductal epithelium and the lumen as such. But when there is a tangential cut, there is a chance of it being mistaken for a malignant infiltration. Therefore, stains such as reticulin and immunohistochemistry will be mandatory for us to rule out a malignancy. So, my dear students, please study the last few subheadings without deleting any of them. Little did we expect that juvenile papillomatosis will be included in the precancerous lesions. There is a huge interval of 5 to 15 years before a malignant transformation occurs. Adults also can be affected, though it is called as juvenile. And sometimes there is already a carcinoma in the background of which we can see a papilloma. Sometimes there can be a bilateral papillomatosis and a family history can also be found out. There are cases where the contralateral breast has been affected. That is about juvenile papillomatosis. Whereas in the case of microglandular adenosis, there are very few cases and it has not been studied to that extent. This is the juvenile papillomatosis wherein you people are finding a Swiss cheese appearance in the breast. Grossly also it is being, microscopically also, it is being reflected by the cystic lesions. Whereas this is appearing more like a lactating breast to me. It appears there is a proliferation of the normal tissue. And whether this has got anything to do with malignancy remains to be seen. And also lesions such as fibroadenoma. There can be cysts, sclerosing adenosis, apocrine changes, etc. My professor used to say it can be called more as a fibroadenomatoid hyperplasia. In fact, if you search between the lines and Ackerman, he would have mentioned that there is an entity called as fibroadenomatoid hyperplasia in a fibrocystic disease of the breast. Adenoma of the nipple is another condition, and this also the follow-up is futile. See what is happening in a fibroadenoma or rather fibroadenomatoid hyperplasia. A florid proliferation I am able to make out of the glands and the ductules, and they are almost back to back in arrangement. Sometimes there can be a branching, there can be a proliferation of the lining epithelium. And this occurs in a background of a fibrocystic disease. Epithelial hyperplasia, cystic dilatation, apocrine changes can also all be made out. And this is an adenoma of the nipple, almost similar to the papilloma that we people have seen. Which of these can lead to malignancy? I would like you people to kindly put your heart, mind, and soul to follow. And these are the references. This is my favorite arborizing pattern that can be seen in a papilloma. Ackerman surgical pathology definitely deals with all this, but then the author of these recent advances have compiled it so very beautifully that you will be able to answer this question without any hesitation. The imagination is how things get done. You should have to cultivate the creativity to achieve this. Thank you.